Welcome to Felony Miami, where we have real conversations with real people about the criminal justice system right here in the US of A. Or walls, steel bars, and a saline drip. Concrete bed, bologna sandwich, convulsions, embolism, heart rate speeding like a freight train through your chest plate. The fear is gripping and real. It's not just that you're going to jail. It's that you might have a medical issue, and the thought of going into the prison healthcare system is causing half of those symptoms you're feeling. From fear that you might get Tylenol to treat stage 4 cancer. You think it sucks to catch the flu in the free world? Try facing down bronchitis in the Dade County Jail. From the courthouse to the jailhouse, the wrong side of the law has its own fully staffed medical facility to treat all the broken jaws, busted eye sockets, and canine bites. But the fact is that the Miami jail medical staff is county and government run. And the Florida prison system, well, that's run by private medical companies whose motivation is profit-based, and that can't be good for the patient. Where there isn't justice for one, there isn't justice for all. Welcome to Felony Miami. Let's air it out. Hello and welcome back to Felony Miami. I'm your host, Joe Stone, and on today's program we have 3 guests. We have returning champion Dr. B in the house. Thank you for being here, Dr. B.
Pleasure to be here.
And directly to my left, I have Dr. Inaki Bent. Welcome to the program.
Thank you.
Dr. Bent works in prisons and takes care of our fellow caged citizens, as our former guest Paul Wright would say. Welcome to the program.
Thank you. Let me correct you there. I work in jails, which are different from prisons.
And how are they different?
Well, so one...
move a little closer to that mic for me. There you go.
So jails are where inmates are taken prior to their sentencing. They haven't been adjudicated.
Okay.
Prisons, you've been adjudicated, and you've been sentenced, and that's where you're going to be housed until you've completed your sentence.
Gotcha. And directly across from me is Dan Marshall. He's a staff attorney at the Human Rights Defense Center. Welcome to the program.
Thank you for having me.
And so what is it that you do over there at the Human Rights Center?
So the Human Rights Defense Center fights for the civil rights of prisoners and detainees and inmates all across the country. We do a bunch of different kinds of cases. Right now, we just filed a case based on a prisoner who died in North Florida, where they literally didn't think this was possible in the United States, but they did literally starve him to death. And so we filed a lawsuit on his family's behalf just a few weeks ago. So we do those kinds of cases, wrongful death cases of prisoners. We also file cases based on the civil rights of prisoners when their constitutional rights have been violated by the staff.
Yeah, so I think one of the problems that we suffer from in this country is that we lock our fellow citizens up, and then we kind of forget about them, out of sight, out of mind, and we forget that these are somebody's children, somebody's brother, somebody's father, somebody's sister, uncle, and that they are people, and that some of those people actually may be there wrongly and should be treated with some kind of basic human dignity.
Basic humanity.
Yeah.
We're Americans.
We are. So one of the things that I have often had a question about in doing this show is we have this huge prison population, of people that we've jailed, and they, besides being fed and bathed and given a place to sleep, one of the things that we forget about is that people suffer from medical issues, and some are much more severe than others. But one of the other big things is that this prison population is aging, and with age comes more problems in the medical sphere. So I've always wondered, how is that actually dealt with? Not only the aging prison population, but just prisoners in general and their medical care. So, Dr. Bent,
Sure.
tell me.
That's an awesome question. A great way to start the show. It's actually a question that I had before I entered into correctional health services. So just a little bit more about me. I currently work as an attending physician through the Jackson Health System in the Correctional Health Services Division. I currently work at the
Jackson is a state hospital in the.
It's a county. It's a county hospital.
Okay, county.
It's a county hospital.
Okay.
Yes.
So the county hospital is it's so the jail hospital or.
So
I'm sorry. Go ahead. I'll let you finish.
Sure.
Yeah.
So, Correctional Health Services is a division of Jackson Health System,
Okay.
which is the county's medical provider. Our tax dollars go to Jackson Health System and all of its subsidiaries. I work at one of 4 facilities within the Miami-Dade Correctional Rehabilitation System. I work at the Turner Guilford Knight Correctional Facility, which is also known as TGK. That's off in Doral. I've been there approximately 5 years. And it's
Doral is West Dade County.
West Dade County, yes.
The Trump resorts are at.
Actually, it is less than a mile away from Trump's resort. Yes, absolutely.
Gotcha.
Poetic.
And it's a pretty sophisticated system. I had my personal preconceived notions about jail correctional health until I dove in and began treating these patients. But it's a pretty well-run system. It's like your average everyday medical center.
Mm-hmm.
Okay, we have a triage area like a mini urgent care.
Mm-hmm.
We have chronic clinics, which are basically our primary care centers. This is how we manage the inmates who are there for an extended period of time.
Right. That suffer from chronic things
Chronic,
like blood
exactly,
pressure
exactly.
issues. Okay.
We have a medical infirmary area for people who need more extensive medical care.
Uh-huh.
Okay. We have a medical infirmary and a medical housing unit. They hold roughly about 40 or so inmates.
Okay.
And those are the locations where we house inmates who may have been released from a hospital who have medical issues that need a little more attention, right?
So I just want to real quick ask Dan, how do you think, Inaki, Dan's question, how do you think somebody was able to starve to death in a prison? I mean, it would seem that if a lot of times prisoners do hunger strikes, but then they take them and they put a nasal feeding tube in, and they're like, "You're not starving yourself here, sir."
Yes.
Right, and in this case, it wasn't that. This was not intentional on the part of the prisoner. Now, he did have some mental health issues.
Okay.
Wait. So this is like murder. Is what you're saying? They purposely deprived them of food.
Well, he had some mental health issues, and so they, over the course of months, this wasn't obviously a split-second thing. Over the course of months, they saw him. He had mental health episodes. He was not eating as much as he should. They saw him wasting away. He was 190 pounds when he went in, and at the time that he died, he was 115. And so they're watching this go on while he's in
negligent
prison.
homicide, so murder.
So
By negligence?
Basically, they did not provide. It's clear to anybody who knows what's going on that this guy needs help, and you can't just hand him his food and walk away, because that's not doing it. And like you said, they do have a duty to not let somebody just die and starve to death.
Sure.
They have to, if it's necessary, they can force feed him, like you said. And here he was not getting the mental health treatment that he needed, and he was not getting the medical treatment that he needed, and they basically just let him waste away.
Inaki, I want to ask you this. To me, the whole mental health care aspect of this is its own program, because that's such a deep and wide topic. I don't even want to really get too far into mental health stuff. I want to try to keep this on the actual, just the clinical side of things. But just briefly, if you could tell us, how do you think something like that would have happened? Don't you think somebody, does the medical staff see just like the general population, or do you only see people when they come to you complaining?
No, as I mentioned before, it's actually a pretty sophisticated system here in our facility. Not quite sure how something like this would have occurred, because at our center, we have protocols in place to keep an eye on things like that, right?
Right.
So by the time he would have gotten to 160 pounds, some medical personnel would have been alerted.
So there's a weigh-in for the patients that's routinely documented?
Well, so patients undergo routine medical evaluations.
Oh, they do?
So they all get screened irrespective of their health
So
status?
like an annual physical?
Exactly.
Gotcha.
Exactly. So before you are received into our facility, once you've gone through mugshots, fingerprints, and whatever processing, you're screened to see if you have any medical issues. If you have any medical issues, you're coming straight to see me, and I'm restarting your medications, and I'm giving you...
But what about somebody that's healthy, that doesn't have any medical issues, but then drops 20 pounds? How is that patient picked up in the system? What screening process is there?
So every inmate who's within our facility, they have access. This is all Bill of Rights, related to the Bill of Rights. This is all monitored by the Department of Justice, but they have the right to request medical care. So if this inmate is concerned about a 10-pound, 20-pound weight loss, they put in what's called a sick call. So that's
what if the patient doesn't have the ability to do that? So this one had mental health issues, and so it sounds like no one flagged the patient. Like how did that patient get brought to your attention?
Well, and just to let you know, and this particular person had been moved around to a few different prisons over the course of, he was actually there for about a year and a half in the prison system. And so every time he goes to a new place, they do the same, way, and they look him. You can see in the records, it's the decrease.
So was this patient ever referred to a physician or a healthcare provider at any point?
Unfortunately, they moved him to a few different units. Like, he did spend a little bit of time in a mental health unit and that kind of stuff, but he clearly never got the actual treatment. It was all kind of like triage stuff. Get him so that he's, not hallucinating the second kind of thing.
I do malpractice cases, and one case in particular, without giving anything away, the failure of care occurred when the screening processes failed. Screening failed. A patient had an illness, kept reporting it, and it would never make it to the level of a physician. As other people intervened, including low-level healthcare professionals, and they never brought it to the level of a physician, and that was the issue there. And so my question, or at least concern, is that was there not someone there that picked this up and said, "Hey, take a look at this guy. He's not eating. He's dropping 20 pounds. How should he have been flagged?" And you're saying that he was triaged, but he never made it to a physician?
Well, no, there were physicians who were there, and the system for him is slightly different than what Dr. Bent's involved in, because it's the prisons, and I know you were saying you deal with the jails.
Yes, very different.
So this was actually the private company, Corizon, who, and you've probably seen them in the news, over the past few years. They don't do it anymore because they were doing it so badly that the contract got canceled.
Gotcha. Okay, can you tell us a little bit more about how Corizon is set up with regards to the prisons?
Sure. So
Corizon is the medical care company that deals with private prisons?
No, they do with all Florida state. I'm actually not sure if they deal with a couple of the private prisons, like the ones run by GEO. But for the prisons that are run by the state of Florida, up until 2012, the state of Florida, the Department of Corrections, they provided the care directly. They hired their own doctors, and so they provided the health care.
So they outsourced it.
In 2012, one of Governor Scott's big campaign promises was to privatize the health care in the prisons. And so they hired Corizon, and Corizon does medical care in prisons all over the country. And so they hired Corizon, and at the time they also hired another company called Wexford, which Wexford had a few prisons and Corizon had the majority. And they hired Corizon to bring in their own staff, and Corizon, the private company, then provided all the medical care.
Can I ask you a question?
Sure.
Did that cut the healthcare budget? Was that a cost saving measure?
That was the rationale behind it. Yes,
Yeah.
was to save money, and because the Corizon came in and said, "Hey, we can do this for cheaper than what you're spending right now."
Yeah, the motivations are all out of whack with that because it's a
Basically, and
profit. It's a profit-based motive, and
Exactly.
yeah, it's completely out of whack.
And they don't make money by providing health care to,
they
to
get money.
prisoners.
They get money,
so.
money per prisoner. Is that how they contract is structured, or is it like a block?
There
kind of
was,
money, no matter how many people are.
it was,
there.
I believe the first one was a block thing. There's a new contract now with a different company that's now that Corizon's not doing it anymore. I believe the Corizon one was just don't quote me on this, but I believe it was just here's a sum to do it for a certain amount of time.
Got it. Okay.
Yeah. And of course, as soon as Corizon took over, like literally within a few months, the deaths spiked up and health problems spiked up, and when something happens in prison, again a little different than the jails, if somebody's having something and they need treatment, they take them to the local hospital, or the clinic, or whatever, and those trips, they dropped off like more than 50%.
The reason why I asked, because it's very different, right? The difference is that he's part of the government system, a county system, and there's very different incentives, right? So cost is not as much of a concern.
Well, let me ask you that.
where
Do
he
you,
practices.
Dr. Ben, do you think about cost when you're dealing with these prisoners?
Absolutely not.
You don't.
Right?
It never crosses your mind.
So, and we'll get into that,
Yeah.
but that we like to think that medical professionals are somehow immune to external forces, and we make judgments solely based on the circumstances at hand with the patient. But we're human beings, and you put us in a certain system, and you'll see exactly what happens, and that's why I'm particularly interested in how this Corizon contract was set up.
Yep.
Which would explain a lot of what you're describing with increase in mortality and other negative indicators of quality of health.
Yep.
But
Yep. I mean, Doc, just like anybody else, if you incentivize not spending money, people are not going to spend money.
Yeah, I mean, but I think there's two sides to that coin, because there are actual benefits to not over prescribing, not over testing, and that is a money saving. And there are companies that are starting now, and that's their whole business plan is, look, we're going to save money, like with Medicare. There's companies, and then you get a bonus if you ended up saving more money.
the entire
for that
government,
patient.
with regard to healthcare, is moving towards that model. Instead of utilization, fee-for-service model, they're doing like block grants or capitated model, basically. So you get a certain amount of money, you make it work, and then whatever you save, you keep. But it incentivizes you to not utilize as much. But then you have to worry about the collateral consequences.
And I think that's fine for people that are on the outside world that have the freedom to complain and bring lawsuits and it's different for somebody that's imprisoned.
Yep. I don't think anybody's ever said prisoners were getting too much health care, so
Exactly.
so when they we're cutting back on what was already in many ways inadequate, you get bad results.
So let me ask you, what's wrong in the correctional healthcare system? What's wrong?
So
It's a deep question.
it is
loaded
a
question.
very deep question. However, I think it's just the negative connotation that comes with the patient population. Okay, so with that,
And when you say the negative connotation, you mean like, oh, these are a bunch of criminals, fuck them?
Exactly.
Because you are human.
Exactly.
Yeah.
Exactly. So I think that's one of the challenges. And with that being said, you may encounter difficulties acquiring qualified applicants, your work pool.
Sure.
Okay, your specialists, your
maybe
your
some
essential-
people
your-
feel fearful that if working in this, what if they want to kill me or beat me or
right. So the quality of care can be definitely affected.
Yeah, because one of the comments that a former guest made about prison doctors was that some of them are like Dr. Mengele. And for those of you who don't know who that is, that's this cat that was really, really messed up during Nazi Germany, prison concentration camps that did horrible, awful things to our fellow human beings. I find that kind of a statement a little jarring because, I mean, to me, it's unthinkable that something like that could occur today, and particularly in this country.
Yeah, I think something like that needs to be described, right? And
Right.
that's why I get back to the point of what's incentivizing these physicians when they practice. Like the homie Knock, that's my homie from college. We go way back. So Doc
Yeah.
Knock, I'm so proud to be here. This is the moment right now, by the way, guys. So, but Dr. Bent, I mean, he's a solid dude. So he does it for the right reasons, and you should never even come closer to putting Dr. Mengele and Dr. Bent in the same sentence. I mean,
Right.
they're two different people. However, if you look at certain systems, right, and I'm sure Dr. Bent can attest to this, if he was in a system that incentivized him or pressured him into doing things that he felt was were immoral or not in the best interest of the patient, you probably wouldn't do it. But back to the Dr. Mengele and the German experience or whatever, with the Nazi camps and all that, there was a lot of social psychology factors going on, and a lot of people were doing a lot of bad things that were just the other day good people, quote unquote, but then you put them in an environment and these people were doing the most despicable things that humankind has ever seen.
Right.
And how did that happen? And social psychology helps describe a lot of that. And
Sure.
and if you look at the environment that a model like Horizon has, you could put good people and incentivize them to do bad things based on other objectives, right? Like getting paid or getting bonuses. And you have some otherwise people who were decent people are being described as Dr. Mengele. And that has a lot to do with the system and the individual, but also the system that they practice in. And the system that Dr. Bent is practicing in does not incentivize that kind of behavior. So it's sort of apples and oranges, but I think you could speak to what incentives are there, because one of the issues that you brought up was the fact that a lot of qualified people would not apply because of the stigma attached to taking care of patients.
Prisoner
But
patients.
yeah, I'm sorry, they're patients, man.
No,
Yeah,
they are
yeah,
patients.
straight up.
And you're saying that
Yeah.
because you're
Yeah.
straight up dying. But I
Yeah.
get what you're saying about that because I'm
no, you're
sure
right.
a lot of people go, oh, they're prisoners.
Yeah.
And again, doing this show, Felony Miami, I've learned a great deal about the whole system. And bottom line is this: look, these people that are incarcerated, they are our fellow citizens. And I may not like some of the acts that some of them may have performed. Some of them may have been when they were young and reckless, and it was a mistake, and it was one time, and now they're paying dearly for that. But nonetheless, they're human beings, and it's difficult. I'm just saying, if it's difficult for me, and I'm pretty liberal, open-minded guy, to have that compassion.
Yeah.
I can't imagine somebody who's outside of this in their own world and trying to pay their own bills, feeling any kind of
Or
pity for.
If you're running a municipality or in office, you need to cut the bills.
Right.
So I'm not going
The
to spend a
state
lot of money.
legislature
I'm not going to spend a lot of money on prisons. That's not going to hurt my voting base at all. Right.
Right.
It's going to improve my voting base. Like I cut the budget. Look at that. you
Yeah,
know?
and that's one of the big problems that goes kind of hand in hand with what you were saying about the stigma attached. Is one of the big problems is just a sheer lack of resources. People don't want to spend money getting health care to prisoners because of the stigma, and they'd rather spend it on other things. And like you were saying, politicians, they don't win votes by doing that. So
it's true.
What if there were less prisoners?
That right there is the key.
That's the key. Everybody's winning, right?
There is the key.
Spending a hell of a lot of
Let's
less
get
money.
less
Huh?
prisoners. Tell me your thoughts, gentlemen, on the drug companies and their relationships with prisons. Tell me what you know about it. Are there special deals cut for the prisons? If there are, how come those special deals aren't cut for regular folk? How does that work? Do we know?
From what I know, the doctors probably have a better idea of this than that. From what I've seen, I'm sure, like, say, Horizon probably has its own deal with it because the bulk that they buy in. However, I can tell you that Horizon and the other, medical companies do their best to not use the drugs. They're doing things like treating cancer with Tylenol and that kind of thing because the drugs are expensive and Tylenol's not. So they,
That's messed up.
whenever they can, they don't use the expensive drugs.
They're incentivized to do that,
Yep.
right? Because you're paying for chemo and whatnot. That you're eating that cost.
No.
But wasn't there a law back when President Bush was in office that they created about not the drug companies not having to do like bulk deals or something?
Oh, so when Part D was
Yeah,
created,
Part
right?
D, yeah.
Is it Part D? I'm getting created the Prescription Drug Coverage Act
Yeah.
back in 2003. I can't remember. Let me get my years correct. Yeah, that's when he
Is
was.
that when they did it?
Might have been a little bit earlier than that.
It was before that.
He was pushing that. Anyways, but the point is that they prevented Medicare from negotiating in bulk, which makes no sense.
Of course.
Yeah. And that was
No,
all lobbying.
it makes sense if you're
If you're
the
big
drug
pharma.
company.
Yeah.
Right.
Yeah, but you literally have these millions of patients, and you could cut a better deal.
Of course.
And we said no, it's illegal to do that. How stupid is that? That's some dumb shit, right?
Yeah, yeah.
And that lets you know like the power of the lobby and big
Yeah.
pharma in our country, because you go to any other country, you can get Eliquis or Pradaxa or whatever expensive medication that exists out there for a fraction of the cost, because these countries were like, no, fuck you, I'm not gonna do business with you. I'm gonna do business with you because you give me a cheaper rate. So I'm gonna take this Pradaxa
Exactly.
at pennies.
Yeah, no,
per
and
patient,
Medicare is a huge thing.
and give it to my patients for free. And
that's-
we can't do that in our own country.
But that's why I'm wondering, can we not do that in our own country on the governmental level, but can the private companies do that? I suppose
they
they
can't.
can.
They can't.
The
So
federal government can't. But
Well, they can do it through the managed Medicare plan. So Part D, what they do is they give these managed plans who provide prescription services. They give them a bulk amount of money, and they need to keep the cost low. So then they cut the deal with the pharmaceutical industry. So that's why you have different drugs that are top tier, depending on the deal that they cut with the drug company.
Mm-hmm.
So that's how they do it, secondarily. But it's still, again, if Medicare had the ability to negotiate in bulk, whew,
Yeah, no, we'd be
Yeah, a
saving
hell of a lot
ourselves
cheaper.
We'd be saving ourselves a lot of
and
money.
then we're not allowed to get prescriptions
Yeah,
across
well,
the,
maybe
across the
one
border.
day-
Maybe
maybe one day the young audience that listens to this program will decide to make some changes on that.
yeah,
at
because
the legislative
that's
level.
stupid, man, and it's not helpful.
But Dr. Bent, do you what's your experience with using the medication for the patients? Do you and dealing with the drug companies?
Because we're a division of a county-run hospital, which is overseen by a public health trust, and you have county commissioners involved, a lot of what goes on is scrutinized heavily. So many of the issues that may arise at a private facility, I haven't seen in my experience at a county-run facility because of the specific partnership. That's not to say that it doesn't go on at these other centers.
Right.
Right.
And I mean, what about the drugs in general? Is there a black market within the prisons or the jails for not just illegal drugs, but like actual?
prescription drug use, yeah.
Yeah, is there?
Well, so I think what you're talking about is contraband, and contraband is an issue at any correctional facility.
Right.
The way it becomes an issue is through the medical services. Patients are receiving medications 24 hours a day.
Right.
These patients oftentimes hoard the drugs, okay? So you have a patient who's taking Tylenol number 3 or Percocet for his chronic back pain, and he's administered the drug and he's cheeking it,
Right.
okay? Or he's swallowing it and goes to the bathroom as soon as the nurse leaves and then throws it back up, and he used that to help barter during his time in the correctional facility. It's a form of currency.
I imagine opiates are a stronger form of currency than blood pressure medicine, but I'm just wondering.
Like, hey, dog, I'll give you some money. Amlodipine.
Well,
I'm low on the torvastatin.
for those cigarettes.
Right. But I mean, with this opioid crisis, it is a big issue we have to be concerned about. I don't know if you remember a few months ago, it was a high-profile incident that happened in the local county jails where some inmates overdosed on fentanyl.
Wow.
Right? So
I did not hear about that.
So it's a legitimate issue.
Wow.
It's a legitimate issue.
So, are you guys doing procedures in the jail that require fentanyl?
No. So I think you misunderstood. That this was a contraband issue.
Right. Okay. So somebody sneaking in
heroin
and
that was
fentanyl
actually
or
not
synthetic
heroin.
fentanyl, because
I'm
that's
not
synthetic
sure.
stuff. I
That-
bet you that synthetic stuff is cheap, easy to access nowadays, and so they may have snuck that stuff
But
into the
it
prison.
seems to kill everybody
So-
that uses it.
Yeah.
That's a problem.
Yes.
So I have a some question about like the basics of how like healthcare is provided in that setting, because I'm unfamiliar with it. And just in general, like if you have, for instance, a diabetic patient, right, which is very common, and they're on insulin, when they get introduced to your system, how is that patient handled? Like, so if I had a family member who was diabetic, what would happen when they get locked up?
Well, so let's start from their arrest. Okay.
Yeah.
So they're arrested. They're brought to the facility.
Yes.
They're screened. They get their mugshot. They get their fingerprints. They're seeing medical personnel who has a checklist of items that they're asking these patients.
This is at the jail.
There's that exactly.
So
yes.
this is somebody that's part of the healthcare system or just a general person?
No, part of the healthcare
Like
system.
a medical assistant of some sort?
Yes,
Okay.
either a medical assistant,
Or
LPN.
Got you.
Exactly. So there's strict a checklist that they go by, and if they meet certain criteria, they are automatically directed to the intake area.
Okay.
So the intake area is essentially like a urgent care ER type facility
Okay.
where we address the immediate needs that are going on right there. But we also address other chronic issues. So that diabetic patient who comes in would have raised eyebrows at the screening, would have been sent over to me, would have gotten finger sticks.
So you see that patient at that level.
At that level, yes.
There's no mid-level between you and that point. So they come straight to you.
Afterwards,
So
yes.
like a medical assistant would then do vitals, or you just straight up see them?
No, they would do vitals.
Okay.
They would be
Like do like the
triaged.
whole
They'd be
intake.
assessed.
Gotcha.
Kind of like a
Exactly.
standard visit to
I see what you're saying.
to an urgent care
Yeah.
center.
Exactly.
And then they get presented to you. And
Exactly.
Do you guys use electronic medical records? Or do you
Yeah,
use paper
yeah.
charts?
We're actually using Cerner. Remember, it's
Yeah,
a Jackson
yeah,
facility.
Cerner, yeah.
It's a Jackson facility.
So you guys use the same system as Jackson,
Exactly.
the Jackson system? That's
Exactly.
pretty
So
cool.
it's an
Yeah.
advantage.
Cerner is a software that's medical.
It's
Yeah. What would they be considered a Jackson patient? Would they be input in the system as a Jackson patient? If they were to go again, that would be
absolutely
part of their chart?
Absolutely. Remember, Correctional Health Services is a division of the Jackson Health System.
Got it.
Right.
So if and when somebody gets out of jail, are they able to access those records if they need to go continue their
Yeah.
health care? If there's an
Absolutely.
issue?
A lot of those patients already go to Jackson, right? So you could pull up their old records and be like, boom, oh, you're on this. So you could do that, right?
Absolutely.
Nice, okay.
Absolutely. That's one of the advantages. That's definitely an advantage. If they need their medical records, they go downtown and request it like any other patient would.
I just want to ask Daniel real quick because in the Tri-County area here between Dade, Broward, Palm Beach, do you guys have records on which one of these counties is got a better healthcare record?
I don't. We don't. We deal more with the prisons aspect of it. So, I mean, we do get some things from county jails as well, because some county jails, especially the big ones, do hire these private companies to do the county jail medical health as well.
Right.
Obviously not Miami-Dade.
What percentage of patients are? What percentage of patients are in jail versus prison in Florida? Do you know what the breakdown is?
I don't know the county jail number. The Florida prison system had, I believe last I checked, was over 100,000
People who
people
are currently in prison.
total prisoners. Now that's not all those people don't have medical issues currently, obviously, but it's a huge number for the state of Florida.
How many people are incarcerated in Florida? You know the statistics on that?
I don't know. We can ask one of our producers.
Yeah.
Jake, can you find out how many people are incarcerated in Florida, please?
Because I want to know, because the correctional system in Jackson, like how many people are in jails in the Miami-Dade County? and how many like patients is Jackson handling, and then you know,
Right. So I'm not sure of the specific numbers, but I can tell you that Miami-Dade County is the nation's 7th largest jail.
Wow.
Okay.
Gotcha.
Oh, wow.
Yeah.
Got you. So should be a lot of people.
Yeah.
So again, so you said you're seeing how many patients a day?
It varies. It varies. I can see. So each shift is 8 hours, so I can see 20 to 25 patients per day. But remember, there are different areas. I'm
Yeah.
the receiving. I'm in the intake,
Right.
but
And-
there's clinics that are going on
Because it's a
simultaneously.
24-hour.
It's a 24-hour facility, right?
So how many patients are you seeing with issues with like related to violence, like people who are being stabbed or
Actually in the jail.
beat up? Like how much of that are you seeing as a physician?
I'd say about a third.
About a third.
A quarter to a third, yes.
How many is that?
That's a lot.
So if I'm seeing 20 patients a day,
Okay, so 6, 7 of them are from violence within the jail.
oh, no, okay. I guess I
Yeah.
misunderstood the question.
Yeah.
So remember, where I'm seeing the patients, they're coming off
Intake.
of the street. They're
Right.
coming in.
Oh, you're doing straight
Right.
up the streets. Yeah.
Right, right.
So
But-
they're
but-
coming in with violent injuries.
Gotcha.
Exactly.
So your role is just intake. You're not doing like, so once you screen the patient, they come in, then somebody's else is taking over from there, like taking care of managing the diabetics, managing the
Exactly.
hypertensive.
If they're there long term,
Yeah.
if they're there long term, then they're following up in the chronic clinic.
Got it.
So, but I'm dealing with the essential medical issues that the patient may come in.
So
So,
if
if the diabetes is out of control,
Yeah, exactly.
the blood pressure is out of control, I'm managing that the same
keep
way
them all
that your
in.
urgent care or your
How long are you managing it for? So if they're in jail for a month, right? They come in, you put them back on their insulin, their antihypertensives, and whatever. Like, what happens once they're there? Like, are you still managing them?
Oh.
Are they still part of your patient?
No.
Okay,
The same way your ER doctor would hand
Exact-
off to
yeah,
the
exactly,
primary,
yeah.
that's basically
So
how
then
that
you
would be
got it.
followed.
How many of that third of patients coming in from violent stuff do you think has been inflicted by the police officers arresting them?
That's a good question. I hear countless stories. Okay, I hear countless stories. Of the third, maybe half of it, half of the third of the patients that I'm seeing with violent,
Yeah.
because they come in with dog bites, canine bites. But I take it all with a grain of salt because sometimes the story doesn't correspond with what the injuries are.
Yeah,
Right?
Gotcha.
Yeah.
But I mean, if are there like injuries that sometimes police might inflict upon somebody that they try to do it in a way that it's difficult for you to find?
I guess so.
only saying
I'm not.
this 'cause
I'm
I
not.
had my ass beat by Leon.
I know you're going somewhere with this.
They mostly hit me on my head, so my hair covered it.
Wow.
Yeah.
Well, were you seen by a doctor after that?
No, I was
Okay,
not
you
seen
didn't
by
make
a
it to the doctor's office. Yeah.
I was seen by my friends telling me, "You need to sue them for police brutality." I said, "I'm not going
But I-
near those people."
I would
Believe me.
imagine that you would be involved in a lot of that, like prisoners who are coming, not prisoners, but people are going to jail who are saying like, the cops did this and they're trying to. So you got to be careful with your documentation. Don't they refer to your reports to substantiate a lot of claims?
So my word is reportedly. Okay,
Yeah,
everything
yeah.
is reportedly.
Gotcha.
Reported. That's how I document it.
Gotcha.
Oh,
So,
really?
So
Reportedly.
yeah. So patient comes in, has sustained facial injuries. Reportedly suffered during his arrest.
So they punched him or something. And then you have the dog bites. So if they sick the canine police dog on them.
Yep.
And have you ever been deposed or asked to come in
No.
for questioning regarding a case?
No.
What other kinds of injuries do you see from the supposedly, reportedly police injuries?
I see fractures, facial fractures, orbital floor
Dang.
fractures are real common. I see several dog bites. Lacerations are big. We stitch up patients regularly in our facility. But that's generally the bulk of those injuries. Those other major injuries are directed to Kendall Regional, Jackson Trauma, or whatever major injuries that are involved.
Okay. And
So
then they come
I have some more questions about like what you guys do in terms of.
By the way, Jake gave me the number on that. Prisoners in Florida, it is 100,000.
Prison. Okay, got it.
It's 100,000. Yeah.
And then versus in jail.
Right, that would be the only in the prison system.
In the prison
Each
system.
county
The jail
jail would
system,
have
I
its
don't
own
know.
number.
Maybe we can
Yeah,
find
no,
that
I want to
out.
know like what the ratio is, because I just need to have the scale in mind. But at least patients in the prison system, you mentioned some startling statistics earlier about when Corizon came on and the increase in the mortality.
Yep.
Like what has been done about that, and do those numbers still exist in the healthcare prison healthcare system?
Yeah, no, they're still not great. They, as I said, Corizon is no longer there. The Florida, when the numbers got so bad that the Florida Department of Corrections actually had to do something about it with Corizon, and so they.
And who caused that action to be taken? Family members, legislative people. Who?
Actually, it's the. There was an expose by the Palm Beach Post a few years ago that put a lot of these numbers together, and when they put it in front of everybody that what was going on, it was so shocking at that point that
Right.
But who's responsible? Who's the healthcare? Is there like a healthcare person that's over healthcare, prison healthcare, that represents the state? Like who's responsible for that?
Julie Jones, who is currently, I don't think she was there at the time that Corizon was first hired, but she's the head of the Department of Corrections now, and so
she's head of the entire Department of Corrections.
Florida Department of Corrections.
Do they have like somebody that's over the healthcare of the Department of Corrections?
Not them, because they have put that with Corizon, or not Corizon now it's Centurion, I believe. But with the private company is the one who's actually running that, and they report to Julie Jones is ultimately responsible for it.
There's no medical professional that could mediate between that two, like a cabinet level person,
well,
kind of thing.
What happened was they started.
That's startling to me.
Yeah,
that's how things like that happen, right?
And they started getting reports about all these ridiculous cancer with Tylenol kind of stuff that I was mentioning, and they actually told Corizon that you need to improve this, or we're going to start fining you under the contract, basically. And at that point, Corizon they canceled the contract. So
Corizon was the one that canceled the contract.
Yeah, because they saw the writing on the wall, I think. But
got it. So they cut their losses, and then what's happening now? Yeah. Who's providing the health care for the prison system now?
Right now, it's another company called Centurion, and the contract. The Corizon was supposed to have a contract that actually ended earlier this year. They bailed on it earlier than that, as I said. But this most recent round of reletting the contract this year, Centurion was the only company who even put in a bid, really. So they got it almost by default.
Got it.
Oh, wow.
And so the jury's still out on
how?
Them.
Yeah, I mean, again, nobody's saying that these prisoners are getting good health care, and they're not entitled to, the excellent, limousine, the top of the line health care, but they are under the Constitution, under the Eighth Amendment, cruel and unusual punishment. They're entitled to adequate health care. You have to,
American,
right?
Basic humanity.
You are a person. If you, if you have cancer, you can't just ignore it like Corizon was doing.
And there's no recourse. I mean, I guess you guys are the recourse and holding them accountable.
It's unfortunate because a lot of the people, I mean, we're talking hundreds of people die each year in prisons. And this isn't, they got into a fight and another prisoner stabbed them. This is, they had some kind of medical condition.
Can you give us the numbers, the exact, the actual, can you quantify what the increase was in death pre-Corizon, post-Corizon?
I believe... if I'm remembering this correct, I believe it went up in the first year from when Corizon took over. It went up 18%.
Okay.
From when the DOC was handling the medical care to when Corizon took over. Mm-hmm. And like I said, Corizon wasn't the only one. Wexford also had some of the prisons too.
But once they went from public to private, they went to the mortality rate increased by 18%.
Right.
What other negative quality measures were there?
Well, the other thing that, again, there are other possible reasons for this, but I mean, I think we kind of know what was going on. But so prior to the private companies taking over, when somebody had a medical issue that couldn't be handled in the prison, they would take them to the local hospital or the clinic, to get them treated because they couldn't handle it at the hospital. Those trips, when the private companies took over, those trips decreased drastically. Again,
How drastically? Is that quantifiable too?
I believe, don't quote me on the exact number, but I believe it was almost cut in half.
Gotcha.
So that,
So they didn't magically get better and require less referrals.
They're going to say, well, we have the expertise, so now we can treat this at the prison rather than having to take them somewhere else. But
so there's never. It sounds to me like there was never any real comprehensive analysis. It sounds like the West Palm did an expose. The West Palm Beach Post.
The Palm Beach Post.
Palm Beach Post did an expose, but it doesn't sound like anybody's ever sat down and really analyzed the problems and then tried to look at what factors were involved.
Right, and I think part of
these negative or potential negative outcomes.
Not as much as we would like to see, and part of the problem I think is because we do, if we get the cases like this guy who starved to death, and we have on our website, we have you said, we have Prison Legal News, which is a magazine that talks about all kinds of different issues that prisoners deal with, and lawsuits that dealing with prison conditions and those kinds of things, from all over the country, and many of them medical related. And we have reports like this from all over the country. It's www.prisonlegalnews.org. Has all these kinds of stories. And what happens is that most of the deaths never result in a lawsuit. So some of them, if they're really bad, like unfortunately, our client who starved to death has a lawsuit filed, but the majority don't. And so the prison companies can kind of look at these lawsuits as almost a cost of doing business kind of thing. And so...
It's part they build that into the budget.
Right,
basically.
right.
Sure.
Absolutely.
So is there a solution? Because the assumption or what we're saying here is that when we went from public to private, and in particular Corizon being the private contract that was signed, that led to inferior care, or that's what we're saying, right?
Right. Yeah.
And so, are you saying that we should go back to the public system? Like, what is the solution? Is there a cost-effective way of providing good care at a good price?
That's the thing. I think the biggest problem is the incentives are misaligned, like we were talking about earlier. Like the incentive isn't so much to actually help people, cure them or fix whatever their problem is. Okay. Now, I'm sure, like Dr. Bent, there are plenty of doctors out there who that's why they became a doctor. They want to help people. But they're not so much incentivized to do. They're incentivized to save money when you're working for Corizon or one of these other companies. And so I would say the biggest solution would be to align the company, Corizon, and their employees, their incentives with actually providing adequate and good care.
Quality metrics, right?
Right.
like A1Cs of your patients.
Dr. Bent, I'm curious because, one of the things that we were talking about was, human suffering. You must get a lot of patients coming in that need to detox from opiates or other types of medications. And how do you guys deal with that? Do you just throw them in the cell and say, deal with it? Or do you offer some sort of path for them to detox without?
Awesome question. So we have a disproportionately high number of patients who are substance abusers. There's a lot of mental illness. We have systems in place to deal with those patients because I would say maybe 40% of the patients that I see regularly are coming in under the influence. Okay, so it's pretty much aligns with how Jackson does it. We have a intake area. They undergo screening once they raise red flags. They are started on a protocol of drugs and monitored periodically as per our protocol to prevent any withdrawal or
Right.
or any issues related to their drug use.
Right. Because I guess there's different types of detox for different types of drugs.
Yes.
Because alcohol detox, if done cold turkey, can actually kill the person.
Absolutely.
Same with like the benzodiazepines, like
Right.
the Valiums and things of that nature. I guess bars,
Correct.
Xanax.
Not as serious as
alcohol?
alcohol dependence, but still
Yeah,
still
still
very
can-
uncomfortable.
Yeah, well,
but,
I mean,
but alcohol dependence that could definitely kill you.
right.
But at our facility, we have a specific unit. That we have
You
an
do.
actual detox unit.
Oh.
So here's my issue with that, and my issue with Jackson in general is how we treat withdrawal or the prevention of withdrawal. Is that I don't think there's enough discussion on the ultimate goal, because if you're going to detox someone, the goal should be to get them off of alcohol. Period. If you're going through the protocol just to go through it when they're going to go out and drink alcohol again, all you're doing is putting them through withdrawal and potentially running into complications without actually helping them. That makes sense? And a lot of hospitals do this without any real thought, right? Because you would be better off with giving them some Jack Daniels while they're there, right? And then letting them decide if they want to get treated versus giving them benzodiazepines and them getting seizures and delirium tremors and diarrhea and all kinds of stuff and ending up intubated. And I've seen this.
Right.
And I've seen a patient go through all this, end up in the ICU, only to go out and go drink alcohol again. So
Right.
like, what do we do just now? Because if
Right.
he had the Jack Daniels, none of that would happen.
Well, but you're talking about two different things
Yeah.
here, because there's the situation of somebody coming in of free will saying, "I've had enough. Please help me,"
Yeah.
and then there's the one of somebody being arrested and they're not going to be able to go to the liquor store tomorrow.
No, what I'm
they're
saying,
not going to be able to go to
you're
the dealer
correct.
down the street. They're not going to be able
But
to
we
get
put them
there.
on benzos, right? And we think that we're doing them a favor, when in fact, if we just gave them some alcohol, that would save everybody money, right? But we would never
but
do
it's
that.
not ethical. But it's not
Sure.
ethical.
Why is that not ethical?
Yeah,
It's not ethical.
Why not?
I understand what you're saying. It's because I'll tell you why it's not ethical. Because
it's not ethical to put them through withdrawal for unnecessary reason. That's unethical because you're risking their life, and you're not helping them, right? There's no real justification for putting them to withdrawal only for them to go out and drink alcohol again.
Yeah, but again,
Right?
you're talking about somebody that's free to walk out and to buy alcohol
No,
tomorrow.
no. But either way, the healthcare system doesn't approach that. Like, so when somebody comes in and they have a broken foot, our first thing is to, like, they're going through withdrawal. Let's put them on benzos, right? And treat the withdrawal symptoms so they don't go through withdrawal, rather than say, give them some Jack Daniels, right?
Sure.
Right. What I'm saying sounds crazy to most people, but it's basic common sense.
No, I understand. So you're saying for somebody that's addicted to alcohol, to use alcohol as the detox.
No. Why are you detoxing them? Is what I'm
Because
saying.
they can die in your custody.
No,
They can die in your
if
care,
if
of
they keep
course.
drinking alcohol, they will not. They'll be fine. They'll be doing exactly what they've been doing and what they're going to do when they leave, right?
Right.
But because they're held hostage because of whatever, because they're in jail or because they have their broken foot, they're sitting there.
Yeah.
We say we're going to bridge them with some benzodiazepines and try to mitigate or tamp down the withdrawal, when in fact we could avoid the withdrawal altogether by giving them some alcohol. And
in a correctional facility.
in
with
fact, they
other-
do that.
I don't think that's
Yo,
gonna
so
work.
but you understand, like it sounds crazy.
I don't see them going for that.
No,
I hate to say.
again, like what I'm saying is that what's your outcome, right? Because at the end of the day, what you're assuming, you could give them alcohol
your
without them
outcome
feeling
is,
good
is
about it.
saving lives.
Because you're actually going to save lives if you did that, right? If you gave them alcohol, you would save people money, and you
But
would
it
save
become-
and you
but
would
then
save
it-
more patients' lives doing that. And it sounds crazy when I say it, but just think about the common sense part of it, because people are getting hung up in alcohol because benzodiazepines is a substitute for alcohol, right?
Right.
A much more expensive substitute for alcohol, a much more less likely way that you would prevent withdrawal, because the best treatment for withdrawal is actually the substance that they've been dependent on.
Correct.
But we give them a synthetic substance to help them, when in fact it costs us more anyway.
So if they
yeah.
were a normal Joe Blow citizen, they
Yeah.
could check into
So-
whatever facility
Right.
and undergo that.
No,
that treatment.
No,
But
I'm not saying
when
that
when you're
treatment
a ward
is.
of
No,
the
but
county,
even-
or
No,
you're
what
a
I'm
ward of
saying,
the
I'm not
state,
saying treat them. Like, there's no reason to treat them. They're not going to quit alcohol, so why are you doing it, right? Anyways, it's a whole nother point, man. I don't think I'm making myself clear.
But some people are ready to quit. This is why.
Yeah, but that's
this
why
is the argument I'm giving you.
Yes.
There are two different things. When you have somebody that's being detained against their will into a jail, okay, and they are not the regular citizen on the street that can tomorrow say, I'm going to buy my fifth of Jack or whatever it is that they're going to do. They can do that. When you're incarcerated, there may be some contraband that you could somehow trade out and get your drug of choice, but if you're incarcerated, there is not an option to go pick up some alcohol. And I understand what you're saying, to use alcohol to get, or to use benzos
if they're in jail for 4 days and then they get out, they're going to be in a hospital because of withdrawal.
4-day stay.
So like I'm giving an example.
For a year.
But there's no discussion about detox. It's just that we're going to treat them and not talk about like the psychosocial factors that's involved and be like, yo, listen, we're going to like you're
I understand
here,
what you're saying,
and it's time for you to get off these drugs, and we're going to treat you and put you in a detox program. We're not just going to give you meds to prevent withdrawal. We're going to detox you, and we're going to get you off of this drug. Like, and that doesn't happen.
So there is something worked in the system that gives the judges who see these inmates the opportunity to go to some sort of inpatient center.
Yeah, like a drug court.
That should be the case. But the physician should have the discretion when somebody comes in and be like, okay, you drink 5 glasses of vodka every day or 10 glasses, you're going to go through withdrawal, right? The first thing that a lot of doctors do is like, all right, we're going to put them on the withdrawal protocol, right? Without even discussing that, listen, you're dependent on alcohol. Right. Are you interested in actually kicking this habit? Because it's going to be a rough road, and you're going to go through a lot. Is this worth it? And this is outside of this. That just never happens. In jail, that particularly never happens.
Right, but the latter is a more long-term process. Right now, you want to deal with the issue at hand.
Yeah, the acute issue of detox, which, as I say, and I know this, alcohol detox can kill people.
Yes.
Benzodiazepine detox can kill people. Opiate detox will not kill you. You might want to feel like you're dead, but it won't kill you.
It can kill you.
Yeah, I don't know about that.
It's very rare cases because it can elevate blood pressure and heart rate. But normally, a heroin or an opiate detox does not require other drugs to detox. It doesn't.
No, you're not. That's not correct at all.
Yes, it is correct. I'm going to tell the doctors, y'all know what the fuck you're talking
about. Have you ever heard of a methadone clinic?
Yeah, but a methadone clinic is the same thing as today's modern Suboxone clinics, and they're not really. They're just a bridge.
Opiate withdrawals is a real deal. I think you're getting opiates and benzos confused. Actually.
No, I'm not.
Okay.
I'm not, and I know this for a fact.
Okay.
Benzos can kill you from detoxing. Opiates, 99% of the time, are not going to kill you. Alcohol will kill you if you're at a certain level of intake on a daily basis.
All right, Doc.
Thank you. Dr. Stone to you, sir. Regardless of that, all I'm saying is this. Marijuana is addictive to some people. Mm-hmm. Not going to kill you if you stop cold turkey.
Exactly.
There are some drugs that are not going to kill you if you stop cold turkey. Let's just leave it at that.
Facts.
There are some drugs that's going to kill you. How does the prison system or the jail system deal with that? And I'm not talking about the social health issue that our country is suffering from with the disease of addiction. I'm talking about people that now are being locked up, handcuffed, caged, and don't have an out. Do you throw them in the cage and say, good luck? Or do you, as Dr. B was saying, give them these protocols, get them clean, and then let them deal with that? How is that process done?
That process, easy. We follow standards of care. That's the standard of care. There have been protocols that have been researched time and time again that are proven that work, and we just follow those.
Okay. Because then there is, like Dr. B is saying, the other half of that, which is the getting clean and then staying clean.
Right.
And there are 12-step programs for that. There are sometimes religious stuff works. Sometimes there are some tried and true methods that
needs to
do
be
work.
kept in mind. Yeah.
Yeah,
Right.
which is the secondary
not.
part. Because there are two parts of it. There's the getting the detox and getting the drugs out of the system so the person can physically function. And then there's the emotional and mental and spiritual aspect of it.
Right.
Which is a whole
right. But we
nother
take an oath
thing.
to first do no harm. That's,
Exactly.
That's what it is, right?
But man, we do a lot of harm with the way we treat withdrawal. We do.
Yeah. I mean, listen, I think using methadone or Suboxone is a horrible way to treat the person. But I do know because I have had personal interaction and family members go through and or die or almost die from alcohol or other types of.
Nah, it's real.
So yeah, it is a real thing.
It's all the way real.
And it's a real thing because I see it in the prisons, and I know people who have gone through the prison system, and I've heard stories of people being just tossed in the cell and saying, "Good luck with that."
Yeah.
And to me, that is a horrible way to treat that. And do those people slip through the cracks with you?
Well, some patients do slip through the cracks. However, a
'Cause
lot
they
of times
they don't report.
They don't report it.
Gotcha.
Yeah, they withhold that information, and you don't know until they're seizing 2 days later.
Wow.
Right?
Yeah,
Wow.
that's a tough area.
And is there a way that during this intake process that maybe a prisoner doesn't report things, that somebody sees them like, hey, no, you clearly have, you're jaundice, you clearly have liver failure or something, or
Yes.
you're swollen. Like you say you're fine, but you have heart failure. Come on, bro.
Yeah.
I'm saying.
Yeah, no, it's all worked into the system. So,
gotcha.
so during the daily huddles, the nurses are giving their instructions. Protocols are reinforced. Even the officers are given some leeway to alert us of any
That's awesome.
medical concerns.
That's awesome.
And do some of those officers do that? I
They
mean,
do.
I imagine
They
there's
do.
got to be some good.
Yeah.
They do.
people.
I
They
do
do.
have a question for you. Do you ever have any officers who put pressure on you, or any correction staff, or any put pressure on let's get this guy. We need to get him processed or get him to the jail, or
From time to time, especially when we get high-profile cases, okay, they kind of sort of get pushed to the head of the line. I really don't have a big issue with that because sometimes it poses a security concern. And at the end of the day, we're on the same team. So it's a give-and-take relationship. So however we can work together to
Facilitate.
ensure these patients get the proper care, I'm down for it.
I have a question about where you think the failure is in terms of the care. Like, is it mostly with the medical providers or like the staff that's at the prisons? Are they
the
not
administrators? You
Yeah,
mean?
it's just people that are interacting with the prisoners. Are they like not underreporting like conditions? Like if a patient has seizures, are they not saying anything, or is it that they're getting to the doctors and the doctors are not making the right decisions?
Yeah, I think it's a combination, and it's not like one answer for every facility in the United States. It's certainly different places have different issues. There is certainly an issue with prison staff, like the guards and that kind of thing, for example, in some places not taking medical issues seriously. And I mean, they probably do have some experience with prisoners who are also malingering. They want to,
that's
they-
true.
Secondary
they-
gain.
right.
And that's something that we don't talk about enough, because we'll attack somebody for not presenting a patient, but there's a lot of we forget that a lot of people fake the symptoms and they have secondary gain objectives that we don't really deal with on a daily basis.
And that's true, and it's not always easy to figure out. But when somebody's health is at stake, I would say they should err on the side of caution.
True.
And then, in addition to that, there is also the problem with the medical providers themselves. The number one goal in many cases appears to be saving money and providing the bare minimum possible. And there's again many stories of prisoners who've seen, they have a condition, they get taken to the local hospital, the local doctor says they need this procedure, they have cancer, they need this done, they need XYZ done, it's urgent, and then nothing happens for another 5 or 6 months, and that kind of thing. So, because it's often because of the medical provider.
Yeah, I would love to see how those contracts are structured, and
that's
a lot of risk that they're taking on.
Yeah, and I'm curious. I mean, does the buck stop with anyone? Is anybody held accountable?
Yeah.
It has to be, from what I've seen, it has to be pretty bad to be held accountable. And the one, like, again, with Corizon in Florida, it got so bad that they ultimately.
But how does that work? Like, I cannot wrap my mind around that. So, like with managed Medicare plans, right? Mm-hmm. You're still bound by CMS rules and regulations, and you have to meet certain standards of care. I'm sorry, the Medicare. Center for Medicare Services, I think.
Okay.
But basically, it's a Medicare central body.
Okay.
And so they're responsible for administering Medicare on behalf of the government,
right.
And a lot of the programs, are managed, meaning that they'll give a private insurance company a block of money and be like, make it work. Mm-hmm. But they still have to meet quality measures in order to be able to qualify and keep that funding in place.
Yes.
Like, how does that work in the prison system?
And there are, in those contracts with Corizon, for example, I know I keep saying Corizon, but there are the other companies too. There are there are benchmarks that they have to meet, and that's actually what the Florida Department of Corrections was threatening them with fines because they weren't meeting those.
And the Florida Department of Corrections are the one, like, how does that work? Like, is the Secretary of Health involved in this? Like, I don't hear any like real medical bodies being overseeing this.
Right.
Like, who's the oversight?
Well, again, Julie Jones, as the head of Department of Corrections,
terrible.
is ultimately the one who decides.
That's not a healthcare administrator. That's not
agreed. But the other way that these companies can be held accountable is through lawsuits such as the ones that we file. Unfortunately, that's only after the fact, and something's gone seriously wrong when something is, when ultimately a lawsuit gets filed. So that's not a great solution either. But
all right, I don't get it. So like for instance, if you have a patient under your care, right, and Corizon is managing them, right, and their blood pressure is consistently 200 over 90, and they're not treating it appropriately. So who holds them responsible? Like who's saying, like, all right, you have these patients and their sugar's not controlled, their diabetes not controlled, their cholesterol's not controlled. They have a foot ulcer that's not healing. Yeah. Like, who holds them accountable?
Yeah.
Because Medicare would hold the managed Medicare plans accountable. They'll get the report to be like, these patients
and
are
then
not.
How would Medicare?
They'll ding them. They'll penalize them financially. They'll withhold money. They could terminate the contract.
Okay.
But there's some surveillance and it's constant.
Yeah.
Right.
And if they're concerned, that's when they do a site visit.
Okay.
But I'm like, who does this for
does
the prison system?
Do site visits for the prisons? Do you ever, doctor?
Yeah. So,
but they're in the Jackson Health systems. That might be different, right?
Correct. It's a different system.
So it is a different system, but we're monitored. Like I mentioned before, this is Department of Justice. So this is all Eighth Amendment related. So
does somebody walk in and look at what you guys are doing?
Absolutely.
Who is that's walking in and looking at you? What you're doing?
So it depends. The big reviewer, the major body is the Department of Justice, so Washington D.C.
Really?
Right. Mm-hmm.
It seems like the current Department of Justice would be super concerned with. It seems like that'd be way down on their list of things to do. Is there a certain department?
But the Jackson Health system is part of. It's part of the.
But that's a county run. Yeah, it's a county run.
But
it's part of the public health trust, right?
Yeah,
right.
But there's an oversight. There's oversight of them.
But there must be oversight in the prisons in the state
yes,
prisons.
And
I'm assuming that there is. I'm just not sure what the oversight is.
They do get audited.
Exactly.
Yeah.
And
audited by who?
I'm not sure of the agency, but it's
if it's a Department of Correction, I'm like, okay.
yeah.
Okay.
That's like the IRS auditing the IRS.
Yeah, no, and it's funny because the audits even come up with examples of records being missing, and there's one prisoner whose medical records had the same vital signs over and over and over again for
Copy paste.
Exactly.
Yeah.
So, so the ultimately they get held accountable by losing the contract, which again a lot has to go wrong before that occurs. And then, as I said, with this most recent round, with Centurion being the only one who was willing to bid, if for some reason Centurion lost the contract or when they canceled the contract, there's nobody else out there who will do it. So
that it would fall
they're
back to
kind of
the
stuck.
state.
Right.
Okay. Which actually might be good for the prisoners.
Yes. It wasn't great even under
for them.
No, if it fell back to the state.
Oh,
And
if
the
it fell
state
back to
took
the
back
state,
over
okay.
and decided to run.
Right. It might be a little better, but it's even when the state was doing it, there were problems then too.
Okay, so it's an area that's problematic.
Goes from trash to trash bag, trash bag to trash.
Well, I'm sure we could talk about this for another hour, but I don't want to beat a dead horse. I'm not sure where that expression came from, but that's your job out there. Find out where that expression came from. Email us and send that back into us. One of the things that we like to do before we wrap up our shows is we like to ask people where they're at musically, because that's a lot of people, the producers. Dr. B is one of our producers. We're all have musical interests, so I'm curious who's on your playlist these days. And actually, one of my big questions lately is, who do you use, Spotify or Apple? Because that's like a big battle right now. Who you listening to? What kind of music you into these days?
So I consider myself a musical connoisseur. It just depends on the day of the week.
Okay.
And I use all the music services: Spotify, Google, Apple, Amazon, Pandora.
Nice.
It just depends. If it's Sunday, it's gospel. If it's Monday, the first day of the week, it's Miami Southern hip hop.
Nice.
Tuesday could be 80s, 90s R&B.
All right.
Wednesday, smooth jazz. And
Give us some names. Give us some.
Oh, some names.
You bumping, man.
Okay.
Let's hear who you're listening to this week.
This week, Drake. Absolutely, I'm a
Okay.
big Drake fan.
Yeah, thank you for admitting it. A lot of dudes don't like to admit it, but
Really?
that dude makes good music, man. You
For
can't
sure.
front on Drake.
Yeah, good music.
Yeah.
He's phenomenal.
Yeah.
He's phenomenal. But I love Southern rap. So, Outkast, Goody Mob, Trick Daddy. I'm big time into the Southern hip hop.
Nice.
Yeah.
Who you listening to, Dan?
Well, so I'm not I don't have a playlist, but I do have a 3-year-old who is taking up all of my time and is bouncing off the walls and everything. So the music I listened to recently has been like Bob the Builder and
Getting honest.
yes.
Some Barney stuff out there.
Yeah. Fortunately not Barney, but
Everybody hates on Barney, but when that kid starts watching Barney and stays quiet for a half hour, you're like all about Barney.
Yeah. So for me, I always give you different answers, but I just got back from Jamaica,
Okay.
and obviously reggae's big over there. And so my homie Shifter is a big reggae artist. I've been bumping his music. He got a new song out with Wayne Wonder. That's fire. Oh, I love it.
Nice.
And then I've been bumping a lot of Afro beats lately.
Okay.
Is it Davido?
Yeah, some of that English
Yeah, man.
stuff.
Oh, man. Like they're
British
from
stuff.
South Africa, Nigeria,
Oh, wow.
Europe. They have a nice sound over there with the Afro beats, and it's like real. It's very similar to the Caribbean music, soca, calypso, and reggae.
Very cool.
But it's very relaxing, and it's a good vibe. So that's my mood now.
Good stuff.
Everything Irie.
Everything Irie. Yeah, me, I'm just checking out what's new in hip hop, and there's this cool lullaby station because I have a 4-week-old at home.
Mm-hmm.
So there's really super cool lullaby station. Then they play like kind of contemporary hits, but cut and a lullaby style, which is very cool.
I gotta hear that.
Yeah.
If you'd like, I can hook you up. When my son was just born, we had a CD that worked for him every time. It was lullabies from around the world in a bunch of different languages. It was like one lullaby from a bunch of different countries.
I love it. Very cool.
It was awesome.
Half of the listeners are saying, "What's a CD?"
Yeah, exactly.
That was an old, inadequate way of storing data. All right. For the Felony Miami team, I'm your host, Joe Stone. Don't forget to check us out on all of your favorite podcast formats, Spotify, Apple, any of the RSS feeds. Give us a listen. Give us a like. Tell your friends about us. Share it and care it. Thanks for listening. For the Felony Miami team, I'm your host, Joe Stone. We'll see you next time.
Well, it's early in the morning, then when I ride, Lordy mama. Well, it's early in the morning, then when I ride. Well, it's early in the morning, baby, when I ride, baby, help me down, help me, help me, my right side.